Well, good afternoon, everybody. Welcome to our weekly Monday afternoon chat. Dr. Michael Jacobs at the Fertility and IVF Center in Miami, here to help you guys get pregnant. Today's topic is why aren't I getting pregnant? Back to the basics. And this may be old hat for a lot of people, but it's always good to go back to why people don't get pregnant quickly, what to expect when trying to get pregnant, and how, as specialists in infertility and reproductive medicine, we go about figuring out what's wrong to give you the best chance of getting pregnant, have a nice healthy baby in the shortest time interval. So, if we look at couples trying to get pregnant, and just in pre-planning phases, if patients say, okay, we're going to stop using whatever contraception we're going to use, whether it's condoms or pills or natural family planning methods, what would we expect in them trying to get pregnant? How many would get pregnant over the next few months or 12-month period? And what you find with, the definition of infertility in the first place is if a couple is not getting pregnant quickly, meaning if under 35 years of age, they've had a year of exposure without any obvious reason from history, that would be considered infertile. And women over 35, even though it sometimes takes longer in older women, we say 6 months. And the reason we say 6 months rather than 18 months is that it's more important to find things quicker because we don't have as much ovarian reserve to use in women that are older, and we'll get to that in a few minutes. So if someone's not getting pregnant quickly, if somebody has a history where they're not getting periods regularly, if someone's had a vasectomy, you don't have to wait 6 months or a year. It's pretty obvious if you never get a period, you're not going to get pregnant. And if your husband had his tubes tied or you've had a tubal ligation, it's not going to happen by a miracle. We need to basically start treating earlier on. So whenever the question comes up, it's a good time to check in with us and see whether you have a problem or not. And then what do we do at that point? If you look at what the causes of infertility are and couples who are not getting pregnant on their own, and you break it down into a male or a female factor, what you're going to find is around 70% of the time you'll identify some cause. Half the time that'll be a female factor, half the time it will be a male factor, and 15% of the time it will be a combination of two, and 15% of the time it'll be unexplained. And to figure out what's going on the male side, obviously we get a history. Is there any previous pregnancies before? Is there any behavior or past surgery that would result in not having good sperm? And by that I mean if somebody obviously had a vasectomy, that's a problem. If they have problems with erection or ejaculation, low libido, and have very suggestive of low testosterone, then that could be a problem. If someone's using medications such as exogenous testosterone, and we don't have a problem with the erectile drugs like Viagra or Cialis or those, but if someone's taking testosterone or androgens at the gym and using active testosterone, that can actually work against somebody as far as their fertility. And use of male hormones often is an easily repairable way to pick up a sperm count. You just stop and hopefully sperm count comes back up. But the key is, how do we test it? We look at sperm. We get a sperm sample. We do what's called a formal semen analysis. You look at the volume of the ejaculate, and you look at the count, motility, and morphology of the sperm. And a normal sperm count, a normal semen analysis would be at least 15 million sperm per cc of fluid. The normal volume is actually less than most people think. Normal volume is just 2 to 3 cc's of ejaculate. It's not a whole lot. A teaspoon is 5 cc's I'm sorry, 15 cc's is a teaspoon. No, teaspoon is 5 cc's. So, it's half a teaspoon is a normal ejaculate, and the concentration of the sperm in that ejaculate is what's important, and that we like to have at least 15 million sperm per cc, and at least 40% of them having active motility, meaning that when you look at them, they're swimming under the microscope, and then the morphology is what the shapes of the sperm look like, and you'd like to see at least 4% of the sperm having a normal oval shape. And that, if that's normal, then that's all we need to do on the guy's side from a sperm assessment. On the female side, there are basically three big questions to answer. One is ovulation taking place? And that you can often deduce from history alone. If you have regular cycles that vary from 25 to 34 days in interval from the beginning of one to the beginning of the next, that's a normal cycle range. But you can have a regular cycle without actually ovulating. So the test that would be helpful to see if you're ovulating, the simplest is a basal body temperature chart. And what you see is after ovulation takes place, the temperature, the set point will rise. So in the second half of the cycle, it will go up. More commonly, patients use ovulation predictor kits. This is the pee on a stick and then put it in a little computer gadget, or some use salivary measurements. But it's basically looking for some hormonal markers to see whether you've released an LH surge, which is a signal to ovulation. And if you have a positive ovulation predictor kit about 13 or 14 days before the next period, which would be in the middle of a cycle if you have a 28 or 30-day cycle, that's pretty strong evidence that you're ovulating on a regular basis. And if there's uncertainty on that happening, we can always obtain a blood progesterone level in the second half of the cycle, around the 21st day of a 28-day cycle. And what that does is it measures the hormone that the ovary makes after ovulation takes place. So you can often figure out if ovulation is occurring without even coming to us. If you have a history of regular cycles, you're getting a positive ovulation predictor kit about 2 weeks before your period comes down. Those two things together imply that you're ovulating. The second big question on the female side is, do you produce good eggs? And that's a little harder to get an answer to. So the things that will give us a hint that you produce good eggs is, one is age. The younger you are, the better your ovarian reserve is, the more eggs that are in the ovary to start with, and the more likelihood that when these eggs are fertilized by sperm, it results in a normal embryo genetically going forward. And what we mean by that is you can have a normal egg and a normal sperm. They fertilize just fine, but naturally, not every embryo develops normally. So when you have what are called errors in meiotic division, the chromosomes, when they go to divide, get mixed up, and you get too many or too few of chromosomal material, and you have an imbalance in the DNA as the embryo is developing, and that's known as an aneuploid embryo. And the incidence of aneuploid embryos changes with age, so that if you have somebody who's under the age of 30, 70% or more of embryos are normal. If you have someone who's 35, we'll see about 50% of embryos that form are genetically aneuploid. Somebody who's age 40, 30% are going to be normal. And then if you get up in the 42, 43 age group, you're going to find that over 80% of embryos are not normal genetically. And that's why it's very difficult for women who are 42, 43 years old to get pregnant quicker, because one, they don't have as many eggs, so they don't produce as many eggs, or as good quality of eggs. And the difference between ovaries and testicles, and men have stem cells, constantly make new sperm. The bad news is on the female side, you only have as many eggs as you started with, and it depletes tremendously as you age, so that the eggs that you have when you're in your late 30s are much less responsive, much less sensitive, don't fertilize as well, don't develop as well, and have a much higher incidence of aneuploidy. And what happens if you form an aneuploid embryo, and that occurs whether it's naturally in your tube when the egg fertilizes, or from an IVF cycle where the egg is fertilized in a dish and the embryos are grown out, and then you biopsy the embryo on the 6th day of development. If that embryo would be placed in a uterus or occur in a uterus, the most common thing that happens is it stops developing and you don't get pregnant, you get your period. The second most common thing that happens is that embryo will stick. It'll develop for 2 or 3 weeks, and usually somewhere between the 7th and the 8th week, 6 to 8 weeks, it stops developing and you have a miscarriage. And the rare event, even at age 40, only 1 in 100 times where you have an embryo that continues to develop that results in a Downs baby or anything like that. So the first thing is do I ovulate? The second is, do I have good ovarian reserve? And the third is the anatomy normal? And the anatomy is referring to the uterus and the tubes. Is the tunnel open? Can the sperm find a way to get through the tubes to find the egg? Because remember, ovulation occurs internally. The ovary releases the egg. The tube has to pick up the egg and transport it back to the uterus, and it gets fertilized somewhere in that passageway back to the uterus. And then when the embryo gets to the uterus, it implants. So the anatomy is looked at by doing a hysterosalpingogram. A hysterosalpingogram is an X-ray where you inject some dye into the uterus. The dye fills the uterus and it goes out the tubes. So the uterus looks like a little funnel and the tubes kind of look like 2 arms coming out on the side. And so a normal hysterosalpingogram will visualize the entirety of the uterus and see the dye go out the tubes. Now, if you have an abnormality, what are the most common things we see in the uterus? Sometimes you'll find endometrial polyps, for instance. And if you have an endometrial polyp in the uterus, it can make it more difficult for an embryo to implant. Polyps don't prevent you from getting pregnant in the long run. If you look at polyps in the short run, there was a study done a couple years ago that did inseminations on patients who had polyps. Some of them got pregnant, some didn't. They removed the polyps, which is easily done through an outpatient surgery called an operative hysteroscopy with polypectomy, with or without a DNC. But you remove the polyps and then treat the same patient again. What you found is that the pregnancy rate is twice as high after the polyps are removed than beforehand. So if we find polyps in the uterus, we would recommend treating them. The natural course over a year or two is they might go away by themselves. They'll slough off with your period. The problem is if you're trying to get pregnant, that doesn't help you that much. That's fine if you have a polyp and you're not trying to get pregnant, you don't have any abnormal bleeding. You can just wait and see, particularly if you're young. But if you're trying to get pregnant, a polyp is a nuisance, and getting rid of that polyp is beneficial. The process of getting rid of it is pretty aggressive. It's just looking with a telescope and physically removing the polyp. It's done as an outpatient surgery with a general anesthesia, and it does not interfere with getting pregnant after that at all. So you would check to see if the uterus is normal. Occasionally you may find scarring in the cavity if there's been previous surgery or severe infection. If there's been a miscarriage where not all the tissue came out at one point. And those are the incidences where you see more scar tissue than otherwise. The tubes being open or not is important, because obviously if the sperm and egg don't have a way to get together, you're not going to get pregnant. So tubal patency is good to know. If the tube is dilated and blocked at the end, it's called a hydrosalpinx. That usually occurs as a result of either past infection, pelvic inflammatory disease, or the hidden or endometriosis or past surgery. So the X-ray is good at at answering the question as to, is there something obviously preventing me from getting pregnant, the tube blocked or unblocked? Is there some partial distortion of the tube in the ovaries so that the tube can't pick up the eggs because they're not ovulating in the same neighborhood and so forth? And if there's an abnormality present, then that guides us on what to do next. If you have a tubal problem, the issue is, can it be repaired? Does it need to be repaired? Or do you just bypass the tubes by doing something like IVF? With the uterus, even if we're doing IVF or intrauterine insemination, you need a normal uterus. So the inside of the uterine cavity is very important to restore to normal no matter what. So those are the key things. Do I ovulate? Do I have good ovarian reserve? Are my tubes open? And the last one is, do I have good ovarian reserve? Ovarian reserve is addressed by, one, asking you how old you are. The younger you are, the better your ovarian reserve is going to be. We already talked about how patients that are older have a higher incidence of aneuploidy and embryos that might not work. There are some patients that are young that have diminished ovarian reserve, and that subgroup of patients, sometimes you need to treat a little more directly and doing things that are a little more aggressive with fertility drugs or IVF rather than a more stepwise approach. You can measure ovarian reserve to look for biologic markers, and the most common one is called AMH, or anti-Müllerian hormone, and that's done at any time during the cycle. A normal AMH level should be over 1.5 to 2. That would be the range. If you're under 35, over 2 is good. If you're in that 35 to 40 range, 1.5 to 2 is fine. When the value gets under 1, we're dealing with an ovary that we don't expect to work very well. When the values are real high and they're 5 to 6, often you'll see that in patients with polycystic ovaries and so forth. So a normal AMH, an ideal one would be in the 2 to 4 range, basically. And acceptable would be up, at least 1.5, and we start seeing more evidence of polycystic ovaries when it's up in the 5 and 6 range. You can also look at the ovary by ultrasound on the 2nd or 3rd day of the cycle, and you can measure the little black spots in the ovary, which are called antral follicles. And a normal ovary will have 5 to 10 per side. People with polycystic ovaries have over 15 to 20. And again, that just gives us a handle on how sensitive the ovary might be to injectable fertility drugs. Basic history is important. Someone had asked a question about HPV on pap smears. That does not affect fertility, basically. If patients have been treated with a LEEP procedure, or a cervical cryo, or a cone biopsy for HPV of a concerning type that would result in dysplasia of the cervix, some of those things may make it a little more difficult if too much of the endocervical canal is affected and there's not a lot of cervical mucus there that can protect the sperm from getting up into the uterus to find the tubes. But HPV in itself doesn't cause infertility, it doesn't cause miscarriage, so it's not an issue. So when someone comes into our office for the first time, what do? Or nowadays, we do Zoom consults for many, many patients, and you don't even need to come into the office to get an idea of what's going on. And part of it is we go through a history. We look for things in both the male and female member of the couple that could contribute to their not getting pregnant quickly, whether there was pelvic inflammatory disease, past surgery, whether there was any infection present. And someone brought up the question of silent infections versus obvious infections. So, what are obvious kinds of infections? You have infections that are in the vagina and infections that are higher up in the reproductive tract. Infections in the vagina, yeast infections, trichomonas, nonspecific vaginitis, vaginalis, Gonorrhea vaginalis, bacterial vaginosis, all the same thing. Any of these things that affect a vaginal discharge and irritation do not cause infertility. They're more of a nuisance, and they can affect the pH of the vaginal mucosa in the vaginal environment, and that can affect sperm survival to some extent. But that's not going to be a stumbling block to preventing pregnancy in the long run. So vaginal discharges are a nuisance we want to treat, but don't really cause any problems. More concerning are infections that would affect the upper reproductive tract. And with that, we're talking about pelvic inflammatory disease that's specifically causing inflammation of the fallopian tubes. The uterus itself is fairly resistant. You can have chronic inflammation in the lining of the uterus, endometritis, and that can predispose to miscarriage or failed implantation. But the only thing that really, infection that destroys the uterus is tuberculosis. All the other ones, it can cause irritation that you can treat with antibiotics. Tubal infections are a little more concerning. And, most people who've had a tubal infection will present with, a fever, pelvic pain, foul discharge, gonorrhea or chlamydia being the two biggest culprits. But both of those can be silent, meaning that you have no symptoms. And a lot of times patients are found to have gonorrhea or chlamydia in their cervix, either on a routine pelvic exam or because one of their sexual partners was diagnosed and they were told to go get checked out. So even if you don't have symptoms and you have evidence of a bacterial infection in the cervix, that should be treated appropriately. You can have tubal disease without any known past pelvic infection or endometriosis. And just because you have chlamydia or gonorrhea doesn't mean you have tubal disease. So you have to do the tests to find out. If the endometrial cavity is inflamed or infected, you treat that with oral antibiotics. You can diagnose that either on a biopsy of the endometrial lining or by visualizing a lot of red splotchy areas in the lining when you do a hysteroscopy. For instance, in our practice, we do hysteroscopies in patients who have recurrent miscarriage. If they have, usually to make sure the cavity is normal. We also do them a lot if people are undergoing treatment and have not had a hysterosalpingogram. So we check to make sure the cavity is fine by looking. The cervix, we do routinely exams for gonorrhea and chlamydia in our office. The other tests, ureaplasma, mycoplasma, you see it more frequently in people who miscarry, but the proof of cause and effect is really lacking. So we treat it when we find it, but we don't do cultures for any other bacteria, basically, because it doesn't help us from a fertility standpoint. So from the standpoint of the basics of fertility, on the male side, it's all about the sperm. On the female side, it's about the eggs, quality, quantity, ability of those eggs to result in normal embryos. It's about the anatomy. Is the uterus and tubes open? The uterus being competent, the tubes being open without a problem. And then basically, is there anything else we need to know about the couple? We do a compatibility test for genetics in patients. And this isn't looking at karyotype as we would for miscarriage. It's looking to see whether there's anything hidden in you that could affect the baby where you're not affected. And a good example of this would be cystic fibrosis. If you are an adult, you would know if you have cystic fibrosis or not. But people can carry an abnormal gene for cystic fibrosis, just like sickle cell. You don't have to have sickle cell disease. You could have sickle cell trait. You can carry a gene for sickle cell and not have the disease. And this does not create a problem for you nor would it create a problem for a baby with the same exact genetic makeup. But if, let's say, if the wife is a carrier for cystic fibrosis and the husband's a carrier for cystic fibrosis, then you would have a 1 in 4 chance of having an affected baby, and that's a big problem. But if, let's say, the wife was a carrier for cystic fibrosis and the husband was a carrier for sickle cell disease, that wouldn't be a problem, because each of you would have a normal chromosome to complement the abnormal one, and as long as you're not both carrying the same abnormality, it's not an issue. So we do that. We do some basic tests for chemistry panel, blood count, thyroid, prolactin, vitamin D. We check that you're immune to German measles and chickenpox, so we can fine-tune any of that stuff beforehand. But the key things, again, sperm count on the male, ovulatory assessment on the female, ovarian reserve assessment on the female, and anatomic assessment on the female. And then with that, we can devise a treatment plan of how best to get a nice healthy baby in a short period of time. There was a question about antihistamines and implantation and IVF. We don't measure anything, we don't test anything. I'm not aware of any good scientific articles that suggest that antihistamines need to be treated or looked at. And one of the problems in IVF in general, when you Dr. Google basically, is what do you look at, who's writing it, why are they writing it, and what application does it have to your particular circumstance. So I think it's real important to, if you're going to go on a website and become educated, we're all for that. But, make sure you know what sites to look at. If you're looking at our site, we know the information is consistent with what we believe in. If you're going to look at other sites, certainly sites that are put out by, National Institute of Health, WebMD is pretty good, Mayo Clinic, these kind of sites, university sites, basically, where there's a fair amount of integrity and honesty in what's being presented. I stay away from a lot of sites that are more advertisement than true medical information sites, and certainly, the blog sites are pretty much really horrible in my mind. They're good to share experiences and so forth, but they're not really good at sharing medical advice with what's going on. So please be careful what you read, and if you read stuff and it's something new or different than we're talking about with you, please bring them up to our attention. We're always willing to learn new things, particularly if they're well documented scientifically from a journal. We're happy to read it, give you feedback on it. But a lot of stuff that you find online may not be applicable to anything that we're going to do. So the key is, getting pregnant. Time-wise, in a younger person, we should see an 18-20% incidence of pregnancy each cycle that you try. In someone who's older, over 40, it's going to be 10%. Again, if you've been trying for 9-10 months, at any age, let us know. If you're older, over 35, then after 6 months, a good time to let us know. We're going to do the basic assessments. We're going to take a good history. We're going to find out where we think the issues are, and then devise a treatment plan that makes sense. And often with fertility treatment, we'll find different avenues to go down. Some of them are simpler, some of them a little more complicated. We do believe in evidence-based medicine, and we will recommend things to you that make sense for us. Often there are a couple of different options that do have different outcomes with them, and you have to balance the chance of success with one direction of treatment versus the other, as well as the cost and the potential of how much time, emotional energy, and physical energy goes into treatment. So we're here to treat you, we're here to educate you, we're here to help you have a nice, healthy baby, and if we could be of further assistance, that would be great. Please let your friends know. Every Monday at 12:30 is a different topic that will be addressed. If anybody has a specific topic that they'd like us to address, please just send us an email, and we're happy to consider it. We thank everybody for participating and asking questions by the chat line, and we'll try and answer them as best we can and incorporate them into the topic of the day. So have a good day, stay safe, and we'll work with you to make it happen. Take care, everybody.